Thank you so much. And first of all, thank you for the kind invitation. I think it's really a great conference and good learning perspective here and move the big three forward. My job is now to look for any yeah, all the others. And I really enjoyed the news from other countries, how they're thinking about coronary calcium and emphysema, and I think we will have an interesting discussion. So on the rest, and I have a statement, and I think it's an issue to discuss. I think there's currently no consensus among radiologists as to the definition, reporting, or management of incidental findings detected at CT screening for lung cancer. There are, however, guidelines from the ACR, from the ERS recently in the UK. I know they're doing guidelines on CT incidental findings. And since we're international and I'm from Europe, I just wanted to show that we read the ECR guidelines as well as the ACR guidelines. And I will show here the ACR guidelines. And for example, here they advise any other nodules. You just look at the fat thing. So any other nodule or mass, right, which is a larger. So we personally, we're very careful with the adrenals, right? There's a lot of over reporting if you report nodules above 1 centimeters on the low dose CT. So if there's not a clear mass, it's large mass over several centimeters, we usually don't call it. The kidney, the same. If there's not a clear mass, a large mass, we typically do not call it. So the liver, you know, there's a lot of hemangiomas which are larger than 1 centimeters. So it's hard to have a specificity on low dose CT with this. So we are very, very hesitant to report them in Germany. And fatty liver, yes, I think it has been shown fatty liver that it is a cause for increased morbidity and mortality. However, at what threshold shall we report it? So this is not defined HU threshold. The pancreas, if you see a cystic mass, I think the abdominal radiologists are all big on IPMN, right? And there have been new guidelines and you have to follow them. And if you see a clearly cystic lesion, probably you should report it. Bone density, I think it's a hot topic because decreased bone mineral density has osteoporosis, has an increased mobility and mortality, and you can do something about it, right? You can treat it. And then we put it out for discussion. If you see a HU less than 100, you should mention it, and they could discuss with the GP the osteoporosis treatment. I personally don't push it forward, but I think it's currently very avidly discussed in Germany. For the aorta, right, we have these cases with a bigger aorta. They're suggesting a threshold of 42 millimeters. Maybe one should move up to 43, 44 millimeters to have a higher specificity and monitor that. But I think we need to agree on a level together where we think it should be reportable. Because all of these findings, if you report them, you make a participant potentially more anxious. Calcium, I skip. Coronary calcium, I skip because we discussed that. The main pulmonary artery, an interest of mine, pulmonary hypertension is a big topic. It's highly underdiagnosed, but I think this threshold is too low in that setting. So I would read the Fleischner guidelines. If there's a low pretest probability, they suggest a threshold of 34 millimeters, for example. Then a big topic, lung fibrosis and ILA. ILA is interstitial lung abnormality, has been shown up to 4%. they recommend that to report it. I think there's some merit in there because you can treat it, and if you catch it early, you can do something about the course because, as you know, some of the ILAs, as IPF, is as deadly as cancer, nearly. Lymph nodes, if they're large, you should report them, but I think this is part of the reporting system anyway. Thyroid, I mean, we're very, very conservative on the thyroid. Goiter is endemic in Germany due to the low iron concentration in the drinking water. So we only report it if we can see an obstruction of the trachea. And here, because Matthias knows this very well, it's a study by you. You did many, many years ago. You may not remember, but you were, he's remembering, yeah. And he investigated nearly 2,000 participants from the Nelson, and he concluded that only clinically relevant findings, incidentally, are shown in 70% of participants, and only 1% of participants had incidental findings with clinical implications, so surgery, for example, all but one being benign diseases. And I think he quoted that the one which was not benign was a pancreatic cancer, if I remember you correctly, and that was already metastatic, and so it didn't have any impact on the patient. So here we did the Hansa study in Germany. It's a multi-center trial at 3 sites in Germany, northern Germany, in Hanover as leading center, and Hamburg, so Groß-Hansdorf and Lübeck. And we look also at the incidental findings, and I have here a preview of the baseline incidental findings and the follow-up incidental findings, and you can see the 3 centers, Hanover, Groß-Hansdorf, and Lübeck, and you see a heterogeneity, right? Between Hanover reporting 170 out of the 5,000, Groß-Hansdorf nearly double, right, reporting the incidental findings. But when you go down and look at where they recommended some follow-up or see a GP or surgery, and this is everything but the coronary calcium and the emphysema, right? Because we also consider this comorbidities, and this is just looking everything but the calcium. It's more homogeneous, you see? It's 162 in Hanover and very similar numbers at the other centers. At the follow-up, it's less numbers, of course, and it's similar. And what did we see? Number one is the desquamative interstitial pneumonia, or RB-ILD. And it's probably only the cases reported where it's sort of obvious, right? But this is a smoking-related disease, right? Everybody has it. So I think we're discussing avidly intensified smoking cessation, combining it with lung cancer screening. So this could be used as a teachable moment to show them. These are only inactive smokers, right? You see those. And to show them what you do to the lung, your lung. And these are I don't have much time to go through it. Kidney masses 2.7%. I just want to point out here ILA 1.5%. So it was a little less than the 4% reported, but I think we maybe overlooked and underdiagnosed it. I just want to show you in the remaining 6 minutes some cases where I think it's treatable as this 1%, right? This treatable, actionable findings. Here in baseline on the right, you see a large mediastinal mass, and it was resected, and it was thymic carcinoma. Here you see a nodule in the breast. Patient had breast cancer. It was a radiation-induced sarcoma after radiation therapy of breast cancer. This one here, we didn't know what to make about, was prominent, but we had to look it up. It was an atheroma, so it was benign. This one is skin thickening there in the axilla. It was an abscess, which was drained, but it's benign, right? And this is one of the rare findings we reported in the thyroid. It's a goiter which clearly obstructs the trachea, and it was resected. The patient, when you asked him, had some in an expiratory problems breathing. Here is a rare case of renal cell carcinoma, which was called and resected. And here a benign disease, but I think it's worth noting it's a loosening of a spinal screw. And when you ask the patients, yeah, I have back pain there. It's worse, but I had surgery, so he thought it would be normal. But this was redone, and screening helped to redo that. This is a case of DIP, right? Discriminative interstitial pneumonia. You see the ground glass, the cystic, but then moving into emphysema. And I would like to show you that case. This is not a screening case. You have a DIP over 4 years in the middle. It moves to more emphysematous and ground glass, and then in the end, it moves to combined fibrosis and emphysema. So it's a continuum. Here's clearly an ILA case where you see that the reticular opacity in the non-dependent portion doesn't go away after a year, especially in the yearly follow-up. You see that, and we call it, and we say go to your interstitial lung disease outpatient clinic, which we have here. And here, look at I can't show, unfortunately. Oh, here. Yeah, look at that dilated airway here, right? We didn't call this. We thought it was dependent atelectasis, but look at the bronchiectasis here occurring. So this is clearly traction bronchiectasis from beginning fibrosis, and that was also sent. And here, more subtle case where you see here ground glass appearing, which is much more than before. And we can learn also from prior studies. This is from I-ELCAP. They could show that respiratory symptoms and acute events with hospital admissions were more frequent with increasing severity of the bronchiectasis score. So we report moderate to severe bronchiectasis. We have a clinic, actually, and they get treated with modern antibiotics these days, and they're specialized pneumologists, at least in our hospitals, who treat those to push down the event rate these days. So from the hazard study summarizing, we learned that indeed less than 1% of participants require treatment, so surgery, like I showed you, for incidental finding in the Hansa trial. It was worthwhile because there were few cancers among them which could be treated. Only incidental findings, we think, warranting definite follow-up or treatment should be reported to reduce harm and healthcare costs of unnecessary downstream procedures. It's a big problem we downtone at the moment in Germany, not to obstruct screening. But I think the only guideline we have in Germany that that we should report on average not more than 10% of the cases, significant reportable findings. In the Hansa trial, as you've seen, various centers reported different frequencies of incidental findings, showed clearly that quality control is needed in lung cancer screening program to assure accurate reporting of clinically relevant findings. So sum up, I think we need standardization internationally. ERS, ACR, and other guidelines need to be harmonized. We need a definition of what's clinically relevant. In Germany, we just have, as I said, a guideline that you should adhere 10% or less reporting. And again, less than 1% of participants require treatment in the Hansa trial. With that, I thank everybody and thank my team.